Welcome, everyone. This is Dr. Jaitly, your cardiologist from New York, on your source of learning cardiology, MuniMeter Health. MuniMeter Health is also your source for your enhancing patient education as well as the clinical medical education. And thank you for associating with us because we are now reaching out to the globe, and I am extremely thankful for supporting my deepest initiative and belief that patient education and medical education both can be combined to improve the clinical outcomes. So thank you again for associating with MuniMeter Health across the globe. First things first, again, if you're having an emergency, please go and see a doctor right away. Go to the hospital, call for an ambulance. 2, if you are preparing for the boards or the exams, please, for my medical students, I always say stick to your syllabus and use this as a supplement. And of course, 3, if you are watching and learning, so please don't take this as a medical advice, but involve yourself into the patient education, a healthy education for health. And this way, whenever you go and see a hospital, your doctors, etc., you're a little better footing to really discuss out the medical conditions that you have been diagnosed with or are in the process of being tested for. Okay, so without any further ado, let's delve into the subject matter. The subject here today is we're going to be talking about the medically urgent causes of chest pain. And what are the medically urgent? Remember, urgent, we're going to specify a little bit more here. Causes of chest pain. And so one of the things that commonly comes into your mind is unstable angina. Okay, so a lot of people are understanding what angina is. Basically, it's an acute ischemic pain resulting from lack of blood supply to the heart. So just to refresh for the medical students, so unstable implying that now it's more of a crescendo variety. In other words, it's increasing in frequency, and it's increasing in intensity, if you will, and increasing in duration, and it's of course increasing sometimes even with less exertion, so less exertion is involved, or sometimes it's also occurring at rest. So when it's occurring, so these are all typical features of unstable angina. Then you have an acute coronary insufficiency, which is very similar to acute or unstable angina rather. And here, of course, some enzymes are normally diagnosed, are helping to diagnose the acute coronary insufficiency. Sometimes you may have an EKG changes as well. But just so that you know, it's very similar to unstable angina. And we'll discuss that more in just a little setting. Non-STEMIs, which are called subendocardial myocardial infarctions. In good old years, we used to call them, but now they are called non-STEMIs. That means there is no elevations of ST segments, and therefore they are end-STEMIs. And then you have STEMIs, which are the real culprit, I guess. So an entire through and through myocardial thickness of the entire wall has been involved. So therefore they are ST elevation MIs, and they are also the acute MIs, we used to call them. Now, so having defined these, then there are other causes like acute pericarditis, which is inflammation of the pericardial, and that's the outside of the heart. There is a little, nature has given every organ a protective sac, so that pericardial sac is inflamed here for whatever reasons, viral, traumatic, inflammatory, or after surgery, or even during the course of, say, other endocrinological or collagen vascular conditions, etc., etc. So that's acute pericarditis. That's again a significant cause of urgent chest pain that needs to be immediately diagnosed and treated. And then you have pulmonary embolism, which is very important. If left untreated, it leads to fatality. So very important. Pulmonary embolism should be diagnosed, which is basically a clot in the artery of the going to the lung, pulmonary artery rather. So pulmonary artery clot, basically we can call it here if you like, pulmonary embolism. And then you have esophageal rupture. And esophageal rupture normally is an emergency because that normally presents with forceful vomiting, mostly in a setting of acute alcoholism, and aspirations can occur. Similarly, they can also result into severe pneumonias and can result into sepsis, which is, as you know, infection in the blood. So esophageal rupture is rather a very It's also called Boerhaave syndrome. Somebody who's interested in knowing about these eponyms, so just remember that: Boerhaves apostrophe. So Boerhaave syndrome. And then the last cause, which also should be included here, is acute dissection, but not the least. So remember, very important is acute dissection of the aorta. So we'll call it acute aortic dissection here. So acute aortic dissection should not be forgotten, because this is very, very important here. So what are the causes? Unstable angina, acute coronary insufficiency, non-STEMIs, STEMIs, acute pericarditis, pulmonary embolism, esophageal rupture, and of course acute dissection. So we can include that here as well, aortic dissection, just to complete the list in order. Okay, so now how do you most of the time diagnose these? It's very important that we diagnose. So there are certain testings that are very involved. So let's understand. Cardiac enzymes can be done at the outset if you're suspecting unstable angina. So you're looking at troponins, you're looking at MB fractions. And normally what happens is the graphs will be the following. If there is a flat graph and cardiac enzymes and MB fractions are not rising, then you know this is not an unstable angina. It's not STEMI, it's non-STEMI. And of course, you could have angina and not raise enzymes, so it doesn't mean that you don't have angina. So again, then further stress testing may be required, etc. So the patient may require to be walked on the treadmill, etc. And then maybe 6 to 12 hours later, after 2 enzymes have been done, patient could be diagnosed for ischemic heart disease if necessary. Okay, so that'll be the scenario there, and you will help. And just simple cardiac enzymes alone will help diagnose those 3 or 4 conditions we just talked about, specifically the STEMIs, the non-STEMIs, and the unstable angina, acute coronary insufficiency. And of course, do not forget the ECG. ECGs will have to be done quite often. So now let's see what the EKG might show. Now this is your normal pattern of your EKG, QRST, PQRST. Now in a setting of unstable angina, what will happen is you'll have, say, ST segment depression here like this, and then a T wave perhaps, or maybe a T waves could be inverted. So you have an ST segment depression. This is ST here is depressed, and the T could be also depressed. So that's one of the ways you can diagnose unstable angina. What will happen in a setting where you have an acute MI? Here you have a PR, and then you have this upward concavity. So an upward concavity, which is here for the ST segment, that'll give you the diagnosis of acute MI. So we'll write an MI here, unstable angina here, and this is of course normal. And then you could look at similarly here, when you have an upward concavity like this, now you have a downward concavity in the ST elevation. So there's an ST elevation, but at the same time a downward concavity. And there's a PR and a PR depression here. It's called the PR depression. So these are the 2 characteristics of acute pericarditis. So just remember that this is pericarditis. So pericarditis will occur, etc. And then, so just remember, an upward concavity is an MI, and downward concavity and with an ST elevation is a pericarditis, and a PR depression, of course. So this definitely will be on the exams, and so just familiarize with this part and this part, definitely. And unstable angina, of course, you'll have ST segment depressions only, so remember the ST segments are depressed. This being the baseline, so ST, anything below that will be depressed, anything above that will be elevated, as simple as that. I'm trying to make it very simple. Of course, you have to again go back to the text and look at which arteries involved, where the ST elevations occur. That will define which areas are in jeopardy, etc. But this is not the focus of this video. The focus of the video here is clearly to show quickly what are the acute causes of chest pain, and how do you quickly arrive at a diagnosis rather quick in the ER settings, or etc. in the consulting clinic levels. So these are some of your areas. Now, the third testing you may involve is the chest X-ray. Now, what would you do if you see a chest X-ray? Well, if you see a chest X-ray which is normal, then of course you've ruled out pretty much cardiomegaly, etc. So let's draw an X-ray here, for instance, and this is your chest X-ray, for instance, and this is your heart here in the middle, which is occupying the mediastinum. And so in a setting where you have, say, esophageal rupture, we just talked about that, the Boerhaave syndrome, what happens is the pneumothorax will start to occur, and we'll show it with a different color here. If the pneumothorax occurs here, the lung is compressed. So the lung will be compressed, and we'll show that in a different color, and that lung collapses. So it'll appear like a chest X-ray will appear in this fashion. So the air being lighter will occupy the top portion of the left thoracic cavity. Say, for instance, this is where the mediastinal rupture has occurred from the esophageal. Now, by the way, the esophagus is right here in the mediastinum. It's like the tube, which is your food pipe, which is sending the blood, which is sending the food down into your stomach, rather like this. So this is your stomach here. So this is where all that food particle is coming in from, food particle, and if somebody is an alcoholic, obviously, because that's normally a setting where esophageal rupture occurs. So just remember that a lot of acute alcoholism, specifically if somebody's presenting with chest pain and forceful vomiting, the chances are this person has Boerhaave's or an esophageal rupture, or may have just aspirated, etc., because they lose their consciousness, and many times they vomit while they are in compromised situations, like fallen on the street, fallen on the floor, or maybe just laying in bed, and etc., etc. So these are some of the areas where aspirations can occur. So chest X-ray will be very helpful. Not only that, the lung collapse and the air will actually start pushing the mediastinum, if you will, more to the right side. So now you have the heart going in this direction. So the heart is pushed to the right side. So now what has happened is the left is already collapsed, the left lung is already collapsed, but the right lung, which was normally ventilating up until now, gets compressed too. Why? Because the heart is now moving into this direction. So even the right lung is involved. So that is, and again, a CT will be very helpful here if somebody orders a CT scan. So CT scan is very helpful because that'll help you localize and tell you where the repair needs to be done by the surgeon. Because remember, esophageal rupture can only be repaired. So you have to take this patient for surgery. So immediately a surgery consultation will have to be done. Patient will have to go to the OR and get the repair done. So this is the setting in where esophageal rupture or Boerhaave syndrome can be diagnosed and quickly taken to the OR in that setting. So CT scan is very, very important. Of course, a chest X-ray is an initial test. ECG and cardiac enzymes we just talked about. They will be very helpful over the next, say, 8 to 12 hours while the patient is being monitored. One can see the graph. If the MB fractions are going up, troponins are going up, similarly in that fashion, then we know that there is an MI happening. But if it is flat, then obviously it's a different issue. So, so we looked at the cardiac enzymes, we looked at the chest X-ray, we looked at the ECG, we looked at a CAT scan. Let's understand what else can be help. Now, remember aortic dissection. Here is your schematic of the aorta. Assuming that this is your arch of the aorta, this is your root of the aorta. Now we have brachiocephalic, the right brachiocephalic coming here, the left subclavian here, and then you have the the left carotid here and the left subclavian here, right? Okay. So quickly we can diagnose that. Just open these arteries up like that. So what do you understand by aortic dissection? Aortic dissection normally implies that you have problems where the endothelial lining is starting to show some tear, and that tear can ascend into the brachiocephalic. This is brachiocephalic. This is your carotid, left carotid, and this is your left subclavian, and this is right brachiocephalic. So, or the tear could be in between this, or the tear could be here, or tear could be lining here. So either of these tears can actually compromise on the circulation. So what do you understand from the tear? So the blood will actually, normally the laminar flow is occurring throughout the aorta in this fashion, right? So that's your laminar flow. But when you have a tear, the blood will actually start seeping within the wall of the aorta, and that compresses the aorta. So what is the effective orifice, or the effective lumen, is getting compromised. You see how it's getting compromised, right? Like that. So this is the compromisation, and therefore the right cerebral hemisphere symptoms can occur if the right brachiocephalic is involved. Left cerebral hemisphere's symptoms, that means right hemiplegia, right hemiparesis, can occur, because remember that it's the opposite side of the body that's being controlled by the left hemisphere. And the left subclavian here will be involved, which will show that there will be lack of pulse. So there might not be any pulse in the left upper extremity. Okay, so CTA is the is the procedure of choice here. Remember that. So order a CTA, that'll help you diagnose the aortic dissection. Now a lot of people have also looked at echo first. They say, why don't we diagnose by an echo? So you could do an echo here, and one can see the heart in this fashion. This will be the aorta, for instance, and of course This continues into the septal wall like that. So you'll draw that, and this is your left ventricle wall here, and this is your posterior wall. This will be seen here, and this is your left atrium, and you have the mitral valve leaflets here. These are your aortic valve leaflets. So the blood is going in this direction, and we'll show it with a different color. Okay, so now what is happening is, so the aortic root can be seen on a 2D echo. Remember, on a 2D echo, one can see a aortic root. So this being the aorta, and this being the left atrium. This is your posterior wall of the left ventricle, and this is your septal wall. Okay, so this is a typical long axis view. So in a long axis view, one can see so actually one can see that the tear can occur, and this tear will be right here within the aortic root. But you cannot complete the entire aortic arch here with the 2D echo. You could certainly do a TE if you like, and when you do a TE, of course, you will see the entire aortic root, for instance, here, and that's the typical root. And then, of course, you will see what it looks like is the lining or the doubling of the wall. Similarly, a doubling of the wall can be seen here as well, but it's mostly at the root. But in the transesophageal echo, you can actually track the entire aorta as well, and then start looking at if there is any tear, etc. But again, this is a semi-invasive test, but nothing like doing a CTA, which will be with contrast, which will help you localize exactly how far your dissection has occurred, whether it's in descending, whether it's in arch, whether it's in the ascending portion, or is there any compromisation within the heart, etc., or there's a leak in the pericardium, which means it's called hemopericardium, and because the blood will now start seeping into the hemipericardium, etc. So these are various testings. So what are we doing? Cardiac enzymes, ECG, chest X-ray, CT scan. We have looked at the CTA here. We have looked at the transesophageal and a 2D echo. So these are very, very important testings in order to complete all of that. Now, 2D echo will also reveal if there was a pericarditis, right? Normally, you would not see a pericarditis on a 2D echo, but if there was an effusion that is sitting, so if there was an effusion like this, so that fluid will be accumulating here in the most dependent portions of the pericardial sac, we call it, and within the pericardial sac like this, there will be fluid here, and that fluid will be the pericardial effusion, if you will. So even a pericardial effusion or pericarditis can be diagnosed by an echo. And of course, as I said, the EKG is diagnostic also for acute pericarditis, where you see a PR depression and then upward concavity. Not upward convexity, but upward concavity. Upward convexity is for MI, and upward concavity is for acute pericarditis. All right. So interesting stuff. And as you see, all these testings I try to make it as simple and creative for you. So this way you can grasp quickly. Cardiac enzymes, of course, getting elevated, as you see in unstable angina, acute coronary STEMIs and non-STEMIs alike, and all these patients eventually will go for coronary angiogram. Remember, do not forget that these patients will require an angiogram to help you localize where exactly which coronaries are involved. And again, my favorite schematic here, the aorta coming out as an offshoot here, and from one sinus, which is the left coronary sinus, arises the left coronary artery, and from the right coronary arises the right coronary cusp, arises the right coronary artery, and these are the various branches. So wherever the blockages there are, those blockages will appear in these fashions, and those blockages can be, again, there are multiple blockages. Obviously, you'll require a bypass, which is called cabbage. But if there are only, proximal and, as I say, passable stenosis, like in this region and this region, and there are not too many, one can do a PCI, which is called percutaneous coronary intervention, or stent. A simple word is stent, where people understand that better. Okay, so this was the focus on this video, and primarily we just wanted to show you exactly where we are with our testings and the immediate diagnostic testings in a setting where somebody's presenting with medically urgent chest pains. Okay, so thank you again for watching MuniMeterHealth, your favorite source of cardiology, and of course, where the goal is to enhance patient education, medical education, to improve the clinical outcomes. So thanks again. This is Dr. Jaitly. So long.